Why don't we get started? And so can everyone take a second and mute themselves? And if you're not sure how to do that, let us know. All right, thank you. My name is Bill Carrick. I'm the president of the American Society of Addiction Nursing, and I want to welcome everyone to our ASAN Summer Webinar Series. This is a culmination of a lot of work by a lot of people, and we hope that you enjoy yourselves over the next 8 weeks. These webinars are free. They're going to be held every Tuesday from July 6th to August 28th. They'll be 1 hour in duration, and we will go over that period of time for questions and answers. You can find the presentation details and slides at the address that you see at the bottom there, addictionnursing.org/summer. Again, I want to welcome you. The American Society of Addiction Nursing was created this year. Was created by a number of founders that felt that there was a void in advocacy of addiction nursing in the United States, and we are trying to fill that void. We've been very, very happy with our response so far. We're moving towards 100
okay
members.
There? You don't need me for anything?
Hi, Darlene, can you mute?
Oh, sorry.
Thank you. All right, you sound like my household, Darlene. Please keep your cameras on, and please mute your microphone. If you have questions, please post questions in the chat box, and we will get to them. There will be daily session surveys. You must complete the daily session surveys. So every webinar you attend, please complete that daily session survey. The link to each session survey is on the schedule page. You can find that again at addictionnursing.org/summer. This conference has been approved for 8 nursing CEUs through the California Board of Nursing. A certificate of completion with CEs will be sent by email with verification that the survey has been completed. You can attend one session, you can attend 2 sessions, or you can attend all sessions. But just remember to complete the survey after each one you attend. All sessions will be recorded and archived on the scheduled page for viewing if attendees are unable to participate in the live sessions. So if you have colleagues that would like to view these sessions, they're more than welcome to. CEs are going to be available for the recorded session viewing as well. Our summer webinar series is posted. Oh, I'm sorry. I'm skipping ahead.
Okay.
Yeah. So this is the American Society of Addiction Nursing Board of Directors. You'll see some of us on this call here. I want to just highlight our Vice President, Suzanne Aluni Kinkle, our Treasurer, Bill Lorman, our Secretary, Ginny Coletti, and we have other board members with us. Carolyn Baird is on the call, Fran Campbell's on the call, and so is Mary Armstrong Fougere. So welcome to all of them, and they've all put in a lot of work for the American Society of Addiction Nursing. I hope that many of you will get to know us. Thank you. This is our summer webinar series. Today, Al Rundio is going to do the theoretical framework of addictions. I'm not going, in the interest of time, you can view this and look at it, and you will just familiarize yourself with it. You can find it again on our web page. Next week, Bill Lorman will be doing a session. I want to introduce now our speaker. Today's session is the theoretical framework for addictions nursing and counseling and education. Our speaker is Al Rundio, and I think you can see quite a few credentials behind Al's name. I'd like to highlight the fact that Al actually started out his career after receiving an associate's degree in nursing. Apparently he liked education so much that he got his bachelor's degree. He lost count of his master's degrees, so he got quite a few of those. And Al actually has a number of doctoral degrees as well. I could go on and on about Al's credentials. Suffice it to say, he's very qualified to give this program. And again, we would like nothing better than for you to join the American Society of Addiction Nursing and become a colleague of Al's. So Al, please take it away.
Okay. So let me put up my other set here. And the first thing I'll start by saying, if you experience any technical difficulty, please let me know. I know Suzanne has my cell phone. I have Comcast as my internet service, and I am hardwired into it. I always do that when I do a presentation rather than use Wi-Fi. But you never know. There's stormy weather at times, and sometimes the internet goes down. So if there's any glitches, just let me know. Or if you can't hear me, let me know. So we're going to have some objectives, obviously, and one is to look at some theoretical frameworks for addiction nursing, counseling, and education, and look at some of the major components of motivational interviewing. And I'm a big believer in what I call scaffolding education. So, you have a theory, but then you kind of build on it. And I tend to be a storyteller and give examples from practice. And hopefully, too, we can even share that at the end. It just doesn't have to be questions and answers. We can all share how we feel about what I'm speaking about tonight. So if you've never been to one of my presentations, if you have, you'll probably say, oh no, not again. But I always introduce my two best friends. And in a live audience, I always ask them, what kind of dog is Logan here? And Logan is a Papillon, and Papillon is French for butterfly. So the way their ears kind of stand up on their head and the way they're colored, from the back, they kind of look like a monarch butterfly. So I have heard of alpha dogs, but Logan is pure alpha. He nips me into shape. He's the one that answers the door to check everybody out. He kind of rules the roost here. And then this is Luke, and we call Luke now the $2 million dog, and that's for a reason. He also is a Papillon. He is actually in his first year of life. If you look, you can see that that he is in a running pen, sort of, because Luke has a medical condition called pica, so he ingests inanimate objects. And in his first year of life, he did it 3 times, and we have a wonderful school up in Philadelphia. Actually, it's the vet hospital and vet school at the University of Pennsylvania, which has not only saved his life 3 times, but a total of 5 times because he's had some other major medical complications. The good news is he's doing very well, and he is he's actually going to be 14 this year, and Logan turned 15 in July. So
Luke,
he's like
the
a
former
two-year-old
$1 million dog.
He's $1 million dog. And of course, I always say he was not an insured American, and the Affordable Care Act wasn't out, so all his care was paid for.
Where'd you stop? Okay.
I have it my
Hassan, if you could mute yourself. Yeah, just remember to mute yourself, okay? All right. So this is Luke today, and we've now kept him ingestion-free for 13 years, and that is with a running pen with remnant vinyl from Home Depot or Lowe's, wherever you want to go, and he really kind of is the love of our life because we've had to nurse him back to health so many times. Well, let's present what you're here for, and let's talk a little bit about substance use disorders and really look at what some of the theoretical models are. So if you look at the disease model, it really gets credited to E.M. Jellinek, and he probably had a very controversial and debated topic in the entire field of substance abuse. And as with many concepts and theoretical models in addiction, it really grew out of alcoholism. If you look at, the 12-step philosophy, which I'm going to talk about tonight, that all really grew out of alcohol. And I can go way back in my career when I did my very first management job, which was a large emergency department. And I really didn't understand recovery or substance use, but all I knew was that patients had to be treated with respect, and they had to be treated like human beings, and they had to be clean, and they had to be fed, and they had to be medically stable. And if that happened in the ER, then I had 2 nurses that I knew of who were in recovery, and I would always refer the patient to those nurses so they could get them into a treatment center.
Hi, Tony.
And it's really kind of a very bittersweet.
Yeah, I don't know why it's on speaker.
Okay.
Yeah,
Tony, give me 1 moment, okay?
sure.
Okay, it really just sharing some history with you. One of
Say
the
that
things.
again, I'm sorry.
We're about to pull up, so I'm calling Nurse
Melissa, can you please mute yourself?
Just a reminder for everyone to mute themselves, because it really is very distracting when you're talking and I'm trying to present and other people are trying to listen. And there are still
So
people who
sorry.
aren't muted. If you don't know how to mute yourself, you should see the mute function kind of as a microphone in the bottom of your screen. Yep. Okay. So what I was going to say, one of the things that I insisted upon was really good treatment. I mean, and I guess what I brought to the table, I was 26 when I was running this ER. It was my first management job. But a lot of our night shift, and we would get a lot of alcoholics because I was working in a inner city ER at the time. And the night shift would just kind of want to get rid of them and get them out in the street. And I said, you can't do that. They could have hit their head. You don't know. They have memory lapses. They have blackouts. They got to be stable before they walk out the store, and they should be referred somewhere. We should get them somewhere. And it was very bittersweet in that I practiced at Atlantic City Medical Center at the time in Atlantic City, New Jersey. And at the time, the city decided to put up a detox unit in an old motel in West Atlantic City on the Black Horse Pike. If you know anything about Atlantic City, kind of a cold turkey detox, wasn't the best thing, but at least they recognized that it was a disease. That's what I'm getting at. And when they dedicated this unit, some of you may have heard of this person, but Mercedes McCambridge, who was an actress who had actually started living for Urin, came down and did the dedication. And the mayor of the city of Atlantic City had invited me to this dedication. So I went, because I was very thrilled that at least the city was looking at this problem for once. And they actually gave me an award for, and it's kind of bittersweet, I always say this, but for opening the doors of the emergency room to someone with substance use disorders. Because before that, it kind of was shut. And I think that that's where this comes. When we look at these models, this is the first time that substance use disorders were recognized as a valid disease, which it is. And then Francesc Boreal Cario took it a little further, where he defined what we call the biopsychosocial model, where there's the whole biological component, which I am a very big believer in, because it's the biology of the brain. It's the neuroreceptors, which, Dr. Lorman's going to speak on that next week, I believe that is. Then there's the whole psyche, there's the whole social part. And then, I'm a big believer that we learn from each other. I learn from my patients when I practice. I think you all do too. And one of my greatest mentors was the medical director that I worked with for 20 years, Dr. Michael DeShields. And what he really taught me about substance use disorders, they're chronic, they're relapsing, and he would even call emergency rooms if they would send the patient out too soon. And he would say, if that was a diabetic, would you send them out that quick if they're not stable? So about the stigma, which I'm going to talk about a little bit later. But to this model, what he added is the spiritual component. And I know work that Stephen Strobe has done, Dr. Stephen Strobe in Poland, that people who engage in spirituality, whatever that is to a person, doesn't have to be religion, right? They tend to maintain recovery for a much longer period of time. So kind of the model that I follow is what I call this biopsychosocial, adding on to it the spiritual component, kind of as a four-pronged model. So at a practical level, it's some way to understand the patient's subjective experience and hopefully will contribute to an accurate diagnosis, good health outcomes, and of course, humane care. So I want to talk about roles. So if you're a nurse, and I'm a nurse, if you're a staff nurse, you can be a nurse manager, whatever you're doing, an educator. But when we look at the nursing role, it's the nursing process. And dependent upon your specific state legislation, nurses are really about 20 kind of professions rolled into one. So my belief is that nurses are counselors. But in some states, when it comes to substance use disorders, they will not permit a nurse to do counseling or to run a group. So I always say you have to look at your respective state legislation. And that's another thing I think we need to do as nurses, very honestly, is to advocate for what nurses should do and try to help each other in states that maybe don't allow that to push legislation, so legislation will let nurses do their complete role. And then if you're an advanced practice nurse, such as a clinical nurse specialist or a nurse practitioner, we usually do some individual client care, or again, if you're a clin spec, you'll be taking care of the nursing staff. And we function as consultants, educators, there's leaders in management, and of course, researchers. So what I do want to review is the 12 steps, because I think this is very important for people to understand. I'm going to go over them, but then you really have to live them. Where I learned the 12 steps best, when I was at the facility that I practice at years ago, the CEO brought the CADC and LCADC curriculum to where I practice, and he paid if you wanted to go. So I was the one nurse practitioner who said, I want to do that. And we had to do in New Jersey 270 hours in the curriculum. And it was every Monday night for 4 hours. And then they took the groups in the state, and we met at what's Cooper University Medical Center in Camden. We met there one Saturday a month for a full Saturday. And then at the end of the curriculum, in order to graduate, you had to do like a 4-day immersion in Perth Amboy. And what we actually did for those 4 days was lived the 12 steps. And so I'm a big believer in the 12-step philosophy. However, I am going to say that not every patient is. And I respect that. One of the things that I do when I do a history and physical exam is I always ask them, do they have a strong support network for recovery? Do they have people supporting them in their family, their friends, their network? And then I always ask them, have you ever attended a 12-step meeting? And a lot of times they won't know what I'm talking about. I'll say an AA meeting or an NA meeting. And the vast majority will have, unless it's their first time in treatment, they will have attended those meetings. And of course, my next question is, do you have a sponsor? However, like this past weekend when I was on Saturday, I asked a patient if they ever attended 12-step meetings. And he said, yes, I went twice, but he goes, very honestly, it's not for me. And I think we have to respect that. It's not going to work for everybody. However, all the research shows that out of everything is one of the best things that keep people into recovery. So at least what I try to do is encourage people to try it, to give it a try. So just quickly over the steps, I'm not going to read everything, but one is admitting that you were powerless. And, what grew of alcohol is now also other substances, that you're powerless over your drugs, be that alcohol or whatever drug it is. That you believe in some higher power. And that power, again, does not have to be God. It can be whatever it is to that person. Step 3, you made the decision to turn your will and lives over to the care of God or this spirituality as you understood it. And then step 4, you did a searching and fearless moral inventory of yourself. Step 5, you admitted to God and yourselves and other human beings the nature of your wrongs. And then step 6, you were ready to have God remove all those defects of character. Step 7, you humbly ask him to remove your shortcomings. Step 8, you made a list of all persons that you had harmed and became willing to make amends to all of them. Step 9, you made direct amends to such people wherever possible, unless doing so would injure or harm them. And step 10, you continued to do a personal inventory. And when you were wrong, you promptly admitted it. Step 11, you sought through prayer, meditation to improve your conscious contact with God as you understood him. It could be her, it's whatever it is to the person. And you prayed only for knowledge of his will for you and the power to carry that out. And step 12 is a spiritual awakening. And you try to carry this message to other people. The reason why I bring it up, a lot of certification exams actually will have test questions on the 12 steps. And what I find, we're lucky in the way treatment is today to get the patient, especially in detox, because usually the average length of stay is 7 or 8 days, then hopefully they go on to a longer term program, which is what we try to do. But in treatment, you're lucky if you get started in step 1. It's a long process, but I think it's something that people need to be aware of. The other thing I want to talk about when you look at your own self, look at your own self, because we all use the defense mechanisms, right? And certainly people with substance use disorders do this, and people have to be tuned to that. So repression is you repress, like it's not happening to me, you repress it. Projection is a great thing that we do as human beings, not only if you have a substance use disorder, but you project things onto other objects or persons. You don't take accountability for it. How many people come in denial? I remember a few years back when I had someone who had an alcohol problem, was an attorney. And he came in on a Friday evening, and I did his physical. And I said to him, gee, you got your 3rd DUI. I said, you must really have a pretty significant problem with alcohol. Oh, no, I don't. I don't have it. I said, really? And he said, no. He said, I just party on Friday nights and weekends and, and then unfortunately I drive and then I get a DUI. I said, well, I would think you would learn from the first DUI, especially in the state of New Jersey, because when you get the 3rd DUI, that's usually jail time. And I said, I still think you have a graver problem than what you think. Oh, no. Nope. And he primarily was there, right? There's internal and external motivation. And the external motivation was going to treatment and trying to demonstrate before a judge that you'd been before treatment so that maybe you wouldn't get as much jail time. So again, denial is a big thing that people have. Again, displacement, you displace the blame onto others. People are intelligent. Substance use disorders hit all facets of life. It's, and some of these people are extremely, extremely intelligent. So they intellectualize why they're doing something. And then, of course, probably one of the biggest thing that a lot of us do as human beings is rationalize, make excuses. So these defense mechanisms are always at work. And if you've ever been a manager, you'll see it in your employees. If you have children, you've seen it there. If husband and wife, it's not just in substance use disorder, but you definitely see it in this patient population. So I want to talk about some of the therapies that are there, and I really want to get to motivational interviewing because I think that's such a critical point to talk about. And then I want to also talk about some terms that we really shouldn't use when we're dealing with substance use disorders, kind of painting this whole fabric of these theories and bringing it to. So behavior therapy is a big thing that we use, right? It's a general approach that looks on the learned aspects of behavior. The general assumption here is that it underlies the behavior therapy is that much of the behavior is termed sick, pathological, or maladaptive. It's acquired by conditioning or observational learning. And basically, there are 3 types of therapies. Some are systematic desensitization, behavior modification, and then assertiveness training. So it happens by conditioning, right? It's how it happens. It focuses on observable behaviors. And when you look at the client, they kind of determine the goals and the therapist assists with the treatment plan. But the behavior is learned and conditioned by external influences through reinforcement. Thus, the behavior can be unlearned. So abnormal behavior then is equated with faulty learning. It's how you learn. It deals with present behaviors. The goal is to eliminate maladaptive behavior and assist in learning new patterns. And the therapist is usually active, directive, and will serve as a teacher and trainer. And some of the techniques are systematic assertiveness training, operant conditioning, contingency contracting, social skills training, stress management, and flooding. And I'm going to give you some examples. I'll give you examples of, how we learn. And I'll also go to dogs as well, because I happen to be a dog lover. I'll start with the dogs. Where I live, which is in the Pine Barrens of New Jersey, in the woods, I'm in a small development of about 13 houses. When we bought, you had to have a minimum of an acre ground because of the Pinelands moratorium. They didn't want to destroy the Pinelands. And so most of the properties around here do not have fences. And most of us have dogs. So it's very interesting. Some of my neighbors, what they did, they put up these dogs to condition them not to go out of the yard. And you could see it. It's kind of a necklace thing that the dog wears, right, around the neck. And then you'll see these white flags all up around the periphery of the yard. And it's very interesting. Like, I'm a bike rider. So when I ride my bike, if the dog would come to like go out of the yard to, try to chase you on the bike, all of a sudden they jam on the brakes not to go beyond the white flag. And that's because if they go out of that periphery, they're going to get a little electric shock to their neck and they jump back. And what happens after 6 months to a year, the flags can come down, right? And then the dog will not go out of that yard. You probably could even take that thing off the neck and the dog, because it's conditioned now to stop at the periphery of the yard. Let's take it to a human being. When I worked at the hospital that I worked at, in the cafeteria, okay, I would, they had a regular cash register, a cashier. So I'd buy my lunch, and if change was coming, right, you'd put your hand out and the cashier would put the change in your hand. This probably the first 5-6 years I worked there, that's how it was. So I am now conditioned to putting my hand out. Then one day they get a new cash register and the coins come down the side of the cash register into a little bucket, and the cashier's not handing you the money. You have to pick it out of the bucket. Well, it took me probably about a week to 10 days to stop putting my hand out to the cashier, because that's how I'm conditioned, and to reach into that bucket. So now I'm reaching into the bucket for a year, and guess what happens? All of a sudden the cash register breaks and we're back to the cashier's handing you the change. And when she's trying to give me the change, I'm reaching for the bucket. That's how we learn. So what you're trying to do, because we have this faulty learning, right? So you try to use techniques to make you relearn. And some of that is through conditioning or contingency contracting. Or an example of flooding would be, how many of you are snake phobics? I am. I don't like snakes. I try to avoid them at all costs, and we have a lot of snakes around here. And there's always in our pool, always in the skimmer, there's always 1 or 2 that I'm getting out every year, and that's not my favorite thing to do. So again, if you want to get to where you're friendly with snakes, you would maybe start where someone hopefully takes a non-venomous snake and lets you hold it, and you get conditioned to it. And then flooding would be, they'll put you into a room with a bunch of snakes. Or I'll use myself as another example. I don't like to fly. People who know me know I'm not a frequent flyer. So you get conditioned to an airplane. There's programs to condition you to that, to get used to it. going over all the safety, and eventually where you take off in flight for a short ride, and then it's a longer ride. Again, flooding so that you can experience it. So again, this can be done individually, in groups or schools or other types of learning institutions. And then cognitive therapy is most associated with the work of Aaron Beck, right? Focuses on replacing maladaptive automatic thoughts with adaptive voluntary ones. It's thinking, cognitive therapy. You know, when I got my PhD, it's actually in education, and we had to learn all the educational theorists. And one was Piaget. And Piaget studied his children. And when he looked at his children, right, up to a certain age, he had what they called concrete operation. Meaning, you know, you tell the child to do something, they do it. Kind of like that conditioned learning. And then after they got to a certain age, I believe it was around 11 or so, as they got older, he saw a difference in them, and he called that formal operations. It's more of cognitive thought. They think differently. Think about it. I always said with every educational program I ever went to, you know, I said sometimes I couldn't pinpoint exactly what I learned maybe, but that I thought differently. It opens your horizons up. So again, cognitive therapy. And then of course we combine the two therapies to cognitive behavioral therapy today. So cognitive distortions are oftentimes a result of irrational thought processes. So the therapist then tries to help the client to develop the logical tools necessary to modify the impact of the automatic thoughts. Now, transactional analysis was developed by Byrne in the early 60s, and the person really has a potential for choice. If you look at Byrne's work and think about it, what I see most in our clients when they go through detox, and even if they go on to the partial care program, we call it the post-withdrawal phase, right? A couple weeks after their detox, is intense anxiety. And that was Byrne's work. And so he said, what a transaction is, it's an interaction between the therapist and the client. And what the goal is to try to get to the root of the client's anxiety so that you can help them. He also brought to the side and to the table that we function in different roles. We can be in a parent role. Hopefully, most of what we do when we're treating clients is that we're in that adult role, but there are times when we're in a child role, you know, creative, intuitive, sometimes being funny. And then again, that transaction is that exchange of strokes, looking at the person's presence, touch, smile, frown, whether positive or negative, and trying to get to what is driving that client. And then motivational interviewing, I think is fascinating. And it was developed by a nurse and also a counselor, you know, Rolnick and Miller. And it is a very directive, client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. It really grew out of the field of substance use disorders, but what you're seeing now, I've had many doctoral students and others doing it in other areas of nursing and medicine. For example, one of my students was on a grant in Pennsylvania looking at motivational interviewing to get diabetics to be more compliant with their medication. So motivational interviewing grew out of the field of substance use disorders, but it really is now going into all areas because it really is a good tool to use. So you really try to elicit the behavior change by helping that client to come up with it, to see it, to resolve that ambivalence. It's goal-directed. Ambivalence and resolving it is the central purpose, and the counselor tends to be
How is it, Connor?
directive in pursuing that goal.
Good.
The motivation for change has to come from the client, not the therapist. You can't impose what you think onto the client. It's the client's task, not the therapist, not the counselors, to articulate and resolve their ambivalence. Direct persuasion is not an effective method. The counseling style is generally quiet and eliciting. and they're directive in trying to help that client examine and resolve the ambivalence. Again, the readiness to change is not necessarily a client trait, but a fluctuating product of an interpersonal interaction. So the therapeutic relationship then is much more like a partnership or companionship rather than an expert and a recipient. So you want to seek to understand the person's frame of reference. Particularly reflective listening is a good skill. Express acceptance and affirmation when the client really identifies the problem. Eliciting and selectively reinforcing the client's own self-motivational statements. Examples, expressions of problem recognition, concern, the desire and intention to change, and the ability to change. And then certainly monitoring that client's degree of readiness to change and ensure that resistance is not generated by jumping ahead of the client. And reaffirm the client's freedom of choice and self-direction. Now, contingency management also gets used in the field of substance use. It differs in the application of the three-term contingency: operant conditioning, which again utilizes stimulus and control, positive reinforcement to change the patient's behavior. And usually the behaviors are rewarded, less often punished. We really don't try to punish a lot today. Generally adherence to a failure or to adhere to program rules or regulations or the treatment plan. And it derives from the science of applied behavior analysis. It produces one of the largest effect sizes out of all the mental health and educational interventions. And where we used it at the one center where I worked, they no longer have a large adolescent program, but we had 42 adolescent patients. And so we used a level system. And, when you're dealing with adolescents, there's got to be consequences. So there was this level system from level 1 to 5. And if they got up to level 5, they had a lot more freedom. They could go out on pass, like on the weekend, because they were there for they would be there anywhere from 3 months to a year. They had more activities that they could do. If they did something wrong, like really bad, they would drop down in level, where then some of the privileges that they achieved got taken away. So you tend to see it. Another example would be a voucher program. The other thing that I think we need to look at too is trauma-informed care. Let's face it, how many of the clients that you see in treatment have some form of PTSD? How many of your clients have maybe been sexually assaulted as a child, or, have today witnessing many of their, their peers, their friends die of overdoses with the opioid epidemic. So I think we all need to get a little bit steeped in the concepts of trauma-informed care. And a lot of centers now are doing trauma groups, trauma-informed care groups and therapy groups for people who have had to deal with a lot of trauma. The other thing I wanted to mention was SBIRT. This is screening, brief intervention, and referral to treatment. This is a comprehensive integrated public health approach to the delivery of early intervention and treatment services for people who abuse substances. It's early identification of potential substance use problems. I once saw a film by an ER physician, and a gentleman had been in a car accident. And when the physician was suturing him, he wasn't accusatory. He was suturing him. He said, when you came in, you weren't awake. We had to wake you up, and, your blood alcohol level was high, which probably contributed to your accident. And he said, did you ever think maybe you have a problem with alcohol? It's kind of like not accusing the person, but getting them to see, this is what I'm seeing. What do you think about it? And certainly if the physician really felt that there was a problem, you would refer them to a counselor in the institution or to whoever to screen them to see if they really need some form of treatment. Even the Joint Commission had adopted this in their survey of hospitals. They were piloting it, that every patient on admission should really be screened for a substance use disorder. And then when we look at the opioid use disorder and the opioid epidemic, there are many tools for SBIRT. Of course, one is the ASSIST tool. When we go to opiates, there's your DSM-5 criteria. We use a COW scale. There's also the OWL scale. And there's also buprenorphine referral forms for opioid use disorders. And then NIDA has the modified assist drug use screening tool as well from the National Institute on Drug Abuse. And new studies have showed that in emergency rooms, if we initiate buprenorphine, it actually even outperforms SBIRT. But now there's a caveat here. I have seen a couple times patients who have come into our treatment center who came from the ER and they were given initial doses of, Suboxone or Subutex. It doesn't happen often though, because a lot of times when the patient presents there, especially with the way the heroin is laced with so much fentanyl and other things today, they're really not ready to get the Subutex or Suboxone because you're going to put them into precipitated withdrawal. So we're finding that we're seeing less of that right now, but when it can be done, and one of the things the ER will do is called a brief negotiation interview for administering buprenorphine, Suboxone, whatever, to clients in the ER. And this was a study done back by D'Onofrio, O'Connor, and Pantalon in 2015 that just shows, it's hard to see the bars, but looking at when they have an intervention and when they have buprenorphine, the outcome's much better. So with counseling and psychotherapy, we kind of talked about motivational interviewing. We talked about some cognitive behavioral approaches like behavioral therapy and cognitive therapy, and then, of course, trauma-informed care. So what do people think about, addiction? What matters? What about statements? Well, there are about 20.2 million individuals who meet criteria for a substance use disorder. And annually, and these estimates will change, folks, but annually we're spending over $800 billion per year, and it's growing. The economic impact from substance use mainly is loss of productivity. There's all the healthcare expenses. There's criminal justice involvement as well. And despite this high prevalence of substance use conditions and about 14,000 treatment facilities and 100,000 recovery mutual aid support chapters meeting weekly across the U.S., only about 10% of individuals get some form of help. There are many more that need help and need to get into treatment. So a main barrier to seeking and receiving help is stigma. This is just breaking down substance use in the United States, looking at how many roughly with alcohol, in the past year with alcohol, millions with an alcohol use disorder only. What about 3.9 million with an illicit drug use disorder only? And when you add it all up, it comes to that 20.2 million adults age 18 or older with past year substance use disorders. So we've got to look at stigma and we've got to look at language. Person first versus problem first. When we look at addict or alcoholic or substance abuse, substance use disorders replace abuse and dependence, medication-assisted treatment versus using the terms replacement or substitution treatment, and stop using words like clean versus dirty. So what words should we avoid then? Well, things like addict, although we still tend to use it. Sometimes I even slip and use it. Junkie, again, we said try to avoid words like clean or dirty. Things like substitution therapy or replacement therapy, or user or habit. And then words that work: addiction, addiction-free, addiction survivor, remission. Remember, substance use disorders are chronic relapsing disorders. It is a chronic disease. I remember I always talk about this guy, Peter, Peter came in, he was a really bad alcoholic. And you got to understand, I have worked in, I'm currently practicing in a not-for-profit facility, but prior to that, I was working in a for-profit facility. And so Peter would come in, he would be detoxed, and then he would go out, and then he would come back in, and then he would go out. I think within probably 4 months, he had been there like he was on his 4th time. And I think I even opened my mouth one time to one of the nurses and said, I think we're just taking the guy's money. I mean, he just relapses as soon as he leaves. Well, guess what? That 4th time he got it. He got it. I am going back probably close to 20 years, and that guy is still in remission. He ended up getting an apartment. He ended up buying a new truck. He actually was coming to me for a couple years for primary care because I understood his disease. I was so proud of him. And so you have to look at this. Yeah, and that's what the medical director I told you before, his name's Dr. Michael DeShields, who is just wonderful, taught me that this is a relapsing chronic illness. So you're never really cured. You're in remission, just like cancer. But you can stay in recovery and remission for a long, long time. Now, I think what's so critical is a recovery system. What we have found in the center I'm currently working, if patients just leave detox and don't go on for further care, either in a partial hospital program or a intensive outpatient program or some form of program, they're the ones we see relapse the most. So it's got to be this continuous recovery of care, but they still relapse. And a lot of the nurses I work, because I practice, Drexel allows us 1 day a week and every other weekend. Every weekend I can do, but I do every other weekend because weekends on our own time. But yeah, we see people come back, but that's the nature of the disease. But we do find the people that get into longer term recovery programs out of detox do much better. So again, they are in remission. And people can be in recovery and remission for a long, long time, an entire lifetime, if they elect to do that. Then we use the term medication-assisted treatment. Again, not replacement treatment or therapy. We call a person with how we define patient and client, and everyone will do it differently. If they're in detox, because that's the acute phase, we call them a patient. When they're in partial hospital care or an IOP or outpatient, we call them client. And then the other word is misuse that you can use. These are just some, major websites. And I think before I end, I just want to give you one example. I had the opportunity, I primarily, as an MP, when I practice, are in the acute detox center. And it's really medicine what I do for most of it. And some counseling and talking to the patient, but I'm not hired to be a counselor, but I have my LCADC. So a few years back, one of the nursing homes was getting a lot of clients who had a substance use disorder, had been like in an acute care hospital setting, and now they were in the nursing home, but they maybe had like a 4 or 5 day detox in the hospital setting, and then all of a sudden they're now in this nursing home for the rehab part, because nursing homes aren't nursing homes anymore. They're really health centers, and most of them have like an intense physical therapy program. It's subacute units. They're kind of like a med-surg unit. And they would have these patients and they wouldn't know what to do with them because they still had the cravings and all the substance use. So they asked me, would I consult on some of their clients? So I went down there about twice a month on a Saturday, and I would see a few patients each time. And I'll never forget how I had this one lady. She was 51, and she was really a bad alcohol use, and had actually bled out a lot, had been in the hospital. Now she was there for therapy and all. And so I was talking to her, and I said, you got to look at what you do. I said, so tell me when you drink. tell me what goes on. What triggers you to drink? What she had a boyfriend, you know, a live-in boyfriend, and she said she owned her own beauty salon. And she said, so when I come home like 2, 3 in the afternoon, around 4, I love to cook. So I start making dinner. And she said, as I'm making dinner, that's when I like to get out some wine and have a glass of wine. But she said, the problem is that I continue to drink the wine and I drink too much. And I said, so here's what you have to do then. I said, that's what you're conditioned to do. And you've been doing it for how many years now? You got to recondition yourself to something else. And she said, well, what would you recommend? I said, well, this is what I would recommend. Does your boyfriend like to cook? And she said, yeah. I said, so I think you let him cook. And maybe at 4 o'clock, do you like to work out? Yeah, go to the gym, work out, or go to an AA meeting. But you got to recondition yourself, because if you go back to doing what you're exactly doing, then you're at high risk for relapse, and you don't want to do that. And I think that's what we have to start doing. And I think we have to individualize our care. One of the things that has upset me for years, whenever I look at discharge notes, and I'm talking probably more counselors right now, everybody's advised to attend a 12-step meeting daily for at least 90 days. You know, it's kind of like, it's like a cookie cutter. It can't be cookie cutter, because what works for one may not work for the other. And I think we need to start getting more focused on individuality and treating the individual person and trying to find out what's going to work for them. So again, these are just some websites that are available to you. And then these are just some references. And I think what I can do now is open it to questions. And for me to do that, that is my contact info. If anyone needs to contact me, that's the best way. And again, these slides are going to be available to you. They'll be posted on the website. And then you'll have all the slides with my information as well if you ever need anything. But what I would like to do is probably get out of here so I can see the chat box to see if there are any questions. So let me do that and stop sharing my screen so I can come back to reality here and go into chat. Okay, and does anyone have any questions? And if not, what I do want to say, if you're new to ASAN tonight, I would encourage you to join. You can't beat the price. And we all, you know, have to work together in this field. We're all passionate about it, and we can all learn from each other, and we can help so many people. And, you know, I just, I hope you join and become a part of the organization if you're not. So with that, I'll be quiet and see if anyone has any questions or getting some comments. Let me try to go up here. Don't forget the other thing that I need to remind you. Someone mentioned, let's see, ASAM. Wait, let me get up here. ASAM is now using the term medication for addiction treatment rather than medication-assisted treatment. And there's a strong evidence base for naltrexone, buprenorphine, et cetera. The other thing I'm a big believer in, I mean, I didn't mention it, it would be another lecture. I didn't do pharmacology. I am also a big believer in Vivitrol. We have, which of course is antagonist therapy, but we have over 50% of our clients on Vivitrol in maintaining sobriety for a year out and more. So I'm also a very big believer in Vivitrol. Okay. And MOUD, medications for opioid use disorder. Yep. Okay. Now here's this. What advice would you give a new nurse interested in becoming board certified in psychiatric nursing or substance abuse? Well, one would be where they're practicing. You have to have so many practice hours. I'm, of course, a big supporter of the CARN, the Certified Addictions Registered Nurse exam. That's where I would, direct them if they want to be certified there. You can go on to the website for CARN and you can access all the information about the exam and what you need to know about that. Certainly for psychiatric nursing, there's also, from ANCC, there's psychiatric nursing board exams as well. So I think it really is dependent upon what the person wants to do. I think the first thing to do, though, you have to have so many practice hours, and it's where do they want to practice? Is it in addictions, or it can be a combination? Like some psychiatric mental health facilities have a strong, a substance use disorder unit as well. So you could get both. I'm a big believer in certification, if you can tell probably by some of what I have, just because I feel that testifies to the public that you have demonstrated knowledge in that area. And I also believe, from doing some expert witnessing for legal issues, I'm right now an expert on 2 substance use centers, addiction treatment centers, where there's lawsuits, and I'm an expert there. And I really think it helps when people are certified. If, God forbid, they get sued, it just shows that you have knowledge in that field, and maybe that's why you did something. So I'm a big believer in certification, especially if you're practicing. I think the webinar, this was a question. I unfortunately missed this webinar. How soon will it be online? I would say probably within the next day or two, because it's being recorded. I'll end the recording when we end the webinar, and then it's being recorded into a cloud. That'll be sent to our executive director, who will put it onto the website. And then you'll be able to access it. Any other questions or anything? Then the other thing I would remind you to get CE, and each one of these presentations is worth 1 CE. So if you go to all 8, it's 8 contact hours. And they do come from the California Board of Nursing. You will have to fill out an evaluation, which will be sent to you within the next day. Bill, I think I'll turn it over to you.
Thank you. Thank you, Al. I wanted to identify that that again, this is a series. It's an 8-part series, and it's meant somewhat to complement each other, but each series, each webinar will also, the presenter has license to go in whatever direction they choose to go. So we'll try to complement and have some kind of consistency. At the same time, as I mentioned, each presenter will have an opportunity to take it in the direction they want to. So I wanted to highlight that. We are very interested in your feedback. We're very interested in your feedback as to how we're going to better meet your needs and advocate for you after this series as well. So we'd be interested to hear what you're interested in and what you'd like presented. The American Society of Addiction Nursing is in its infancy. It's not a year old, and yet we have 35 participants tonight. So I want to thank so many of you for joining us at this point in time. I also want to highlight a few things. I see a lot of BSNs, RNs, MSNs. I see a couple LPNs. Our organization is for all nurses, and we've coined a few phrases similar to all nurses are addiction nurses. And that's how we would like that's how we would like our organization to grow. And so from the licensed vocational nurse, the licensed practical nurse, to a doctorate level nurse, to nursing students, we'd like to include you all so that we can, again, as Al so eloquently put it, provide education and advocacy for the client and to be able to reach out to the client and provide the best care. Lastly, we're also an organization that is Nurses for Nurses. And we hope to build on that kind of concept in which if a nurse is in need for assistance, we can reach out or provide resources. I happen to be a nurse in recovery as well as a nurse that works in recovery. And ASAN has a fair amount of nurses that are currently in recovery, and we welcome nurses in recovery. So, so I look forward to seeing many of these same faces next week. And if anybody has any questions about ASAN, myself and the board of directors is actually on this webinar. We'd be happy to take any questions you might have about ASAN as well. Other than that, you're welcome to leave the webinar and start filling in your questionnaire.
There was one more question, and it let me see if I can read it. I want to get my master's and plan on getting a psych mental health MP, which is a great degree to have. But I'm having trouble finding a program. I don't want to do an online program because I think a master's is not meant to be learned online. Now, of course, here you're talking to the wrong person. I'm only kidding. I teach online and I teach in the graduate programs. The only thing I will say, COVID probably caused most universities to go online for a year, unfortunately. But I know what you're saying. I mean, and truthfully, all my education, other than my DMP, all my education was done in person. I traveled up to Philadelphia from South Jersey to like Penn and LaSalle and those kind of places. And there are still programs that are not online. So I would recommend doing a Google search and look at where you're located, look at the universities closest to you, because of course you have to travel. I have to say, I did elect to do a DMP deliberately online, because teaching online, I wanted to see if I learned that way. And I actually loved it, you know, because I didn't have to travel. And believe it or not, you do connect virtually, and there are, the way the technology is today, it's really rather incredible. However, I understand that it's not for everyone, and it's not. Online's not for everyone, but there are programs around. I would start looking in your state and what's closest to you, looking at your universities, call them. Psych mental health MP programs, I would say more are probably increasing. A lot of schools are increasing with that because it's become a very hot degree to get. So you should hopefully be able to find someone. And there's also, if you go, there's also, you know, college books that you can buy on all the universities they offer. So I think that was it, but let me see, just to make sure. Here's a question, Bill. So what is the evolution of ASAN? I see that many of the leaders were leaders in INSA. Why the separate organization is one question.
Yeah, thank you. The International Nurses Society of Addiction, they serve a great purpose. Their focus has moved towards international, as their name identifies, and
It's funny. It's funny.
yeah, as best I can put it, we felt there was a void in the advocacy of addiction nursing in the United States, and so a number of founders elected to start this organization. Now, to be truthful and to be transparent, a number of these founders also were not necessarily welcome with the International Nurses Society of Addictions any longer, because we questioned some of the motives behind, at least what we believe were some of the motives behind the process that the International Nurses Society of Addictions was using in moving into the international direction. So it wasn't necessarily a mutual. we didn't mutually leave the organization. It wasn't something that we did willingly. But once we did leave the organization, once we were excused from the organization, we decided to create the American Society of Addiction Nursing, again, with a focus to advocate for addiction nursing in the United States. So that's what our focus is going to be. I think there's certainly room for both organizations. And again, we applaud the International Nurses Society on Addictions in their work with the international subset. So I don't know if that answers your question. I'm happy to take a follow-up, Marianne.
And Bill, can I add also that we also opened it up to LPNs, who we see as valuable nurses in the addiction field?
Well, the reality is, I just know down where I practice in South Jersey, and I don't know in other areas of the country, but a lot of our even detox units, but especially residential, are staffed by LPNs. So they certainly need to be included because they're a key part. You know, it's all about interprofessional work today, and we need each other, and we need all levels of staff to make the place run and to provide good care. So I think it's great that this organization does acknowledge and accept LPNs.
I also want to add that we would certainly welcome any international members. So it's not exclusive in that way by any means.
And in fact, we do have some international members.
We do, yes.
So I want to thank you for that and for your focus on U.S. Addictions, knowledge, and treatment. You're correct that a lot of the work in the trenches is done by licensed practical nurses, though they are fewer and fewer because there are so few schools that are training licensed practical nurses now, especially in Washington State. But I do much prefer inclusivity rather than exclusivity because addictions affect so many of us in our country, and the problems have certainly gotten worse with COVID, and we need as many people on board and to support them because it's challenging work. So thanks to all of you who are working in the field and welcoming your colleagues to participate.
Thank you, Marianne.
Okay.
Great.
Well, thank you everyone for being here. It's been great.
Thank you. And next week, Bill Lorman will be providing the neurobiology behind addictions. Is that correct?
That's correct. Yeah.
All right.
Same
Very good.
time, same day. We've kept it on Tuesdays at 7 p.m. Eastern time.
Thank you all.
Bye-bye.
Bye-bye.
Good night,
Thank
everyone.
you.